any spay-neuter program, you have to have safe and efficient protocols for anesthesia. That includes drug selection, perioperative care, monitoring, and the overall anesthetic technique. They all have to be carefully designed to allow you to neuter large numbers of animals in a short period of time safely. All right? And so this is a laundry list of the things under anesthetic procedures that we'll talk about: perioperative thermoregulation, anesthetic equipment, oxygen supplementation and ventilation strategies, airway management, fluid therapy, patient monitoring, anesthetic protocols, accurate dosing of anesthetic agents, administration of analgesics and anxiolytics, total intramuscular anesthesia, induction and maintenance with inhalant anesthetics, and mitigating waste gas exposure in high-risk patients. Now, I'm not a board-certified anesthesiologist. Fortunately, we have one in the room. So when you come up with anesthesia-related questions, I may very well look at Emily McCobb and say, help. But you want to have active patient warming systems in place. Now that can be anything from warm air blankets to circulating warm water blankets, or the new, I think they call them hot dogs, the semiconductive polymer fabric heating blankets. But you need to have a system in place to keep the animal's temperature, at the appropriate level. This is especially important in the pediatrics. I jokingly say, put a 2-pound kitten on a stainless steel table and measure the temperature of both and see who wins. What you've got to do, everything in the process, everything from when that animal first is brought into the clinic until it goes home, you have to pay attention to keeping that animal's body temperature at an adequate level. All right. The recommended housing body temperature, the recommended housing temperature where animals are held is between 64 and 84 degrees. All right. You want them in a place where there's minimal drafts. You want to keep the animals dry. You want to have them insulated from cold surfaces. You don't take, it's most important in the pediatrics, but it's appropriate for everyone. You don't simply take them and put them on the floor of a stainless steel cage. All right? There's got to be something insulating them from the cold surfaces. When you prep the animals for surgery, in veterinary school, we teach people to make 8-inch spay incisions in 12-inch animals, and to clip enough hair that you could extend. You can extend the incision to Vermont. All right, but again, especially in those pediatrics, you've got to clip enough hair to allow the surgeon to extend the incision if necessary. But you have to keep that balanced with the more hair you clip, the more that animal is going to lose body heat. And then another thing that a lot of the people who teach surgery don't really think about is the bigger that abdominal incision is, the more body heat that's lost from the abdomen. And oh, by the way, the bigger that abdominal incision is, the longer it takes to close, and the longer that animal is on the surgery table, the more body heat it loses. So it's an argument for minimal hair clipping, but enough, teeny little incisions, get them on and off the table quickly. All right, you've got to have a system in place to check the anesthetic equipment every single day. All right, these anesthesia machines may be used on 30, 40, 50 or more patients per day. Don't just trust that, oh, we checked it last Tuesday, everything's okay. You have to have a system in place to check those anesthetic machines regularly, every day. You've got to have a regular maintenance schedule. You've got to check those CO2 absorbent canisters and change them regularly. Again, it's contingent upon the volume of surgery, but in these high volume settings, you're going to be changing those canisters very frequently. You have to have anesthetic waste gas systems in place. All right. You want to have the ability to provide oxygen supplementation when it's required. All right. And it's always recommended for high-risk patients, brachiocephalics, frail patients, animals that are showing clinical signs of disease, or animals that are in advanced stages of pregnancy. But it's not required to give every patient oxygen. It's not a requirement. All right. Our system, we use total intramuscular anesthesia. We don't intubate on a routine basis. We have endotracheal tubes. We have anesthetic machines. We have the ability to intubate. We have the ability to give oxygen. We will routinely intubate basically two classes of animals, brachiocephalic and morbidly obese. Those are the ones we routinely intubate and get on the anesthetic machines. Most of the rest, we don't intubate, and we don't provide oxygen supplementation. Dogs and cats. All right. Now, there's been that research study in dogs, and help me out if in cats, and help me out if there's anything been published in cats about that show that the risk of complications when you intubate cats for surgical procedures that are less than 30 minutes long, the risk of complication is greater with the intubation than without intubation. I don't think that's the same in dogs, but our program, we do not routinely intubate the animals, except in obese and brachiocephalics. Yes. Wonderful. Thank you. You want to have you have to have ventilation strategies. Again, that doesn't mean that they all have to be ventilated, but you have to have the ability to do it. All right. I think I've already said a lot of this. Routine intubation is not required. The document specifically says routine intubation is not required. Why in writing these guidelines do we include things like that? It's because we know there's veterinarians out there who don't, in high-volume clinics, that don't routinely intubate, where the practitioner 5 miles down the road that hates the fact that there's a spay-neuter clinic in town might make a complaint to a state board saying, you know, they don't routinely intubate. Now you can pick up these documents when the state board contacts you and says, but published in the AVMA journal, it's not required. It gives you some level of defense. All right? It's not required, but you have to have the equipment and supplies and the skills to intubate when it's medically necessary. All right? Fluid therapy is not required. But the ability to administer fluids, having the fluids available, having the equipment necessary and the skills to do it is required. All right? Fluid therapy is recommended in those animals in advanced stages of pregnancy, those animals with pyometra, anytime there's a significant blood loss, anytime the surgery is prolonged. We don't define prolonged in the document. You have to judge that. All right? In my mind, prolonged would be, oh my God, it's more than 20 minutes. All right? Or any other high-risk situations that the veterinarian recognizes you want to give fluids. I'll get your question in a second. All right? But for those routine elective surgeries, spay-neuter surgeries, that are going to be on and off the table quickly, and the surgical times are so short, and the amount of trauma in the surgery is so minimal, fluid therapy is not required.
What about those cats that you're trapped? You know, you trap them, you do the surgery, and then you keep them overnight. and you only discharge them tomorrow after you look. So you don't give them sub-Q fluids or anything like that because they're not going to be in that cage or that.
So the question is, what about those community cats that are in traps and they're not going to be handled? They're not. Nobody's going to be in there changing out food bowls and this type of and water bowls. But you're probably going to keep them in that trap overnight till the next day. What about sub-Q fluids? Absolutely. I don't think the guidelines, I don't remember the guidelines getting that specific, but that would be one of those situations where, as the veterinarian, you're going to judge, all right, this animal's been in a trap for 24 hours, it's going to be here for another 24 hours, and it's so stressed out it might not drink anyway, even if we provided him water, or her water. We should give some sub-Q fluids. Perfect example. Thank you. Yes?
Do you still give IV fluids to all your pregnant ferals during pregnancy season?
Do we give IV fluids to all of our pregnant ferals? I would say the answer to that is no, unless, in those, those pregnant ferals that are 8.5 months pregnant, yes. But on a routine basis, no. All right, monitoring the patients under their anesthesia is essential, and there's probably nothing better than vigilant hands-on monitoring. You want someone that can determine pulse quality, rate, and rhythm. You want someone that can determine respiratory rate and pattern. You want someone that judges jaw tone, can look at eye position, pupil size, and palpebral reflexes. All right. They should be monitored from the time the administration of pre-medications or anesthetic agents through the anesthetic recovery. All right. Does that mean that there's someone sitting there constantly, like in vet school, where someone was monitoring 57 parameters every 12 seconds for a 3-hour spay? No, but it means someone that is periodically checking these patients to make sure everything is okay. All right. There's more objective means of monitoring devices: Doppler ultrasound, pulse oximetry, capnography, blood pressure monitoring. All right. The guidelines don't get into are any of those specifically required, but they do say that the use of pulse oximetry is highly encouraged. All right. The specific anesthetic protocol that you use is really up to the discretion of the veterinarian. It depends so much on the types of patients and the number of surgeries you do. It depends on the skill and the efficiency of the technical staff you have. It depends upon the competence of the surgical staff. Is this surgeon someone that's, I mentioned last night, someone who's doing cat space, 5-inch incisions taking 2 hours? Is that the level of surgery, or is this the 5-minute cat spay? And obviously on drug availability. It should be balanced anesthesia that provides all the standard things: analgesia, stress reduction, anxiolysis, immobility and muscle relaxation, and safe, controlled, reversible depression of the CNS. And I think that reversible is so important in those pediatrics. We use total intramuscular anesthesia, and we don't routinely reverse except in pediatrics. But we will routinely reverse our pediatrics, and we can have puppies and kittens playing in their cage and eating 45 minutes after surgery with reversal. All right. Avoid the one-size-all fits anesthesia dosing. 1 million years ago, when I was an intern at the ASPCA and a surgical resident at the ASPCA, I took a part-time job on Saturdays at a place called Bushby in New York City. I don't know if any of you work for Bushby or whatever, and if I do, recognize this is in the 70s, and I suspect things have changed. We would have a 1 o'clock in the afternoon appointment for all cat castrations. Every cat castration got 1 cc of ketamine IV, was immediately castrated and put back in a carrier. And there was a common time when all the patients, all those cat castrations were picked up, and the speech was, "Don't open the carrier until tomorrow." Avoid that. Avoid. That's true. I mean, that's true. We did that. Avoid, accurate body weights with the dosing of the anesthetic appropriate for that body weight. And that's so important in those pediatrics, all right, because there's a huge difference between a 2-pound kitten and a 3-pound kitten. All right, so the dose has to be based upon that body weight. All right, but back to the community cats, those cats that are going to eat you for lunch. All right, then the critical thing is you may be estimating body weight. All right, but you want to avoid drugs that cause severe cardiovascular depression, and you want to use reversible drugs. So if you estimate wrong, above all else, do no harm. You can escape that problem. All right. Volume by weight charts are very, very helpful. We don't have, well, I guess now everybody has smartphones, so we do have calculators on our mobile units, but we don't ever have someone trying to calculate out the dosage of an anesthetic drug because it's all on the charts posted right at the station. All right. I think we've already talked about most of this. Obviously, analgesics are required for all patients and should be administered prior to the initial surgical incision. Total intramuscular anesthesia, in which a single injection includes everything, is useful and acceptable. We specifically state in that document that the total intramuscular anesthetic protocols are acceptable. Again, you may very well have that private practitioner down the road who's complaining about the clinic because you're not using gas anesthesia, not intubating, whatever. Now you have something to defend yourselves. This next point is a significant change, or at least a change, from the 2008 document. All right, the 2008 document basically said that anticholinergics were not recommended. All right, and recent studies have said, wait a minute, that may not be the right course of action. So now we're simply saying they should be available in all spay-neuter clinics for individual patient and emergency use, and they may or may not be part of your anesthetic protocol. It's really up to the individual veterinarians now to decide. All right, so ASV has stepped back away from that thought that they are not recommended. All right. Mask induction of anesthesia. All right. If you're not using total intramuscular, but you're going to do something else, you should avoid using mask induction. All right. It's poorly controlled. The patients are stressed to the max. There's phenomenal environmental contamination when you try to induce an animal with a mask. All right. Chamber induction is just as bad and is rarely justified. All right. Mask maintenance is appropriate on an as-needed basis. All right. So if you're not routinely intubating, it's perfectly acceptable to maintain them with a face mask. All right. And the comment, it may be safer in cats to use mask maintenance than intubation. All right. If mask supplementation of anesthetic agent is a very frequent occurrence, you probably should look back at your overall protocol and see if that needs to be adjusted. All right. So what about those high-risk patients? All right. Oh, question in the back.
The masking. How about with rabbits?
The question was, what about mask induction with rabbits, right?
Okay, so with regards to rabbits, what the guideline says is that for maintaining anesthesia in dogs, cats, or rabbits, you can use intubation, a mask, or an LMA. We didn't specifically address induction technique of rabbits specifically in the guidelines. I personally believe that a well-sedated rabbit using sevoflurane induction via a mask is probably fine. And we'll go into a little more detail about this whole masking, boxing and stuff in the last talk, but when you get into a little more detail, it's not that we're saying thou shalt never mask an animal down. What we're saying is that there are a lot of adverse effects that need to be considered, and if the animal's not well sedated, it's not really humane, and it does increase the risk of complications in dogs. Mask induction does, and also the big issue with masking in all contexts is environmental contamination of your staff. So you really have to make the best decision for the situation you have at hand, using the resources that you have at hand. And the guidelines are designed to be flexible to allow that.
All right. So in that high-risk patient, though, we're back to the veterinarian must assess risk-benefit. You know, and this is one of those patients we would always intubate. We would modify our anesthetic protocol in the morbidly obese, all right? And there's obviously other situations where you may find yourself saying, wait a minute, I'm not sure the anesthetic protocol that I routinely use is appropriate for this animal because of whatever, all right? So alternatives to your standard protocol may include intubation, may include using drugs that are less cardiovascular or cardiorespiratory depressing, may include reversible agents, certainly may include supplemental oxygen and supplemental fluids. So all of those categories are things that you should have the ability to do in your high-quality, high-volume clinic, and then use when the requirements of the specific patient dictate something other than your standard protocol. And obviously, when you have that situation, the risk should be communicated to the owner or the authorized agent prior to induction of anesthesia and prior to surgery. All right. Under surgical care, again, the laundry list, and I won't read the whole list, but what you want is you want spay-neuter surgical practices to be based on accepted principles of infection control, surgical asepsis, and appropriate surgical technique. And if you do that, it optimizes surgical success and decreases the risk of complications. Right? You want surgical procedures that are efficient. You want the surgical times to be shorter. And both of those improve patient recovery and reduce complications. Right? The incidence of complications, of anesthetic and surgical complications, is directly proportional to the length of time the animal is under anesthesia and undergoing surgery. So more efficient, shorter surgical times are going to be beneficial for the patient. All right? So under the operating environment, and here is a change. The operating, in the 2008 document, it said the operating environment should be an environment restricted to the surgical procedure. And then went on minimal traffic flow and all of the appropriate things. All right? And there was a veterinarian brought up in front of a state board where the attorneys for the state board were using the 2008 document to criticize the veterinarian. Why? Because they set up a recovery beach in the surgery room. So the wording has been modified to say the operating environment should be restricted to anesthesia, surgery, and an immediate post-op recovery. If you've got personnel, you've got the surgeon and you've got another person in the room that's helping monitor anesthesia, there's probably no safer place to begin the recovery of the patient than in that OR room on that beach. Anybody familiar with the term when we use beach? It's a Humane Alliance thing where, an insulated, padded surface on the floor. It's hard to fall off a floor when you're recovering. And you can keep the animals warm, and you have personnel that can watch those animals very closely. But in that particular case, in front of a state board, the veterinarian was being crucified for recovering animals on a beach. So that's why we've changed the wording. All right. You want the necessary equipment, obviously, for anesthesia and patient monitoring. You have to limit, in the OR environment, limit traffic to the essential personnel, and you have to have a regularly scheduled sanitation procedures. All right. For surgical packs, every surgical procedure, every patient should have separate sterile instruments. That does not always equate to a separate sterile pack. That feral cat castration clinic, where you have a stainless steel tray that has a paper towel, a hemostat, a couple gauze sponges, and then a paper towel and a hemostat and a couple gauze sponges, and you stack them up 15 high. Every patient then is getting a new sterile gauze sponges, new hemostats, but it was all in one pack. That's appropriate. The requirement is separate sterile instruments for each patient, not designating how those are packaged, if you will. All right. Obviously, the instrument should be clean prior to sterilize. The method of sterilization, steam, gas, plasma are all appropriate. What is missing from here is cold sterilization. It's not considered appropriate. The date of sterilization and the person responsible for sterilization should be indicated on the pack, and sterility indicators should be both inside and outside the pack. All right. Patient preparation, the bladder. It's best if the bladder is emptied by whatever method you feel comfortable emptying the bladder. It simplifies the surgeries in those abdominal procedures. It increases patient comfort postoperatively. All right. The skin prep area should be large enough to allow the surgery to be performed and the incision to be extended if there's a dropped pedicle or whatever, but not so large that it begins to compromise thermoregulation. You want to use an appropriate surgical scrub. You want to position the animals in a way that avoids compression of the thorax and avoids hyperextension of the limbs. All right, that avoids hyperextension of the limbs is new. It was put in the document because there is, I don't believe there's a research study, but there's a lot of belief that those animals where the front limbs are tied, to one end of the table, like this, it's kind of like putting the animal on the rack, make it much more difficult to exteriorize the ovaries because it tenses the suspensory ligaments. All right, so as long as those limbs are loose or down by the side, wonderful, but not hyperextension. All right, draping is required. There's not a whole lot of things in the guidelines that say required, but this is one. Draping is required for all abdominal procedures and is required for castration of adult dogs. All right, and the drape should be large enough to provide a sterile field and minimize or prevent contamination without trying to indicate exactly how big the drape should be. That's the surgeon's discretion. All right. The guidelines specifically state that feline castrations and pediatric canine castrations, draping is optional at the surgeon's discretion. All right. If they don't drape, though, care must be taken to prevent contamination. All right. And again, that's put in there to give high volume spay-neuter surgeons a defense. Do we cord tie the puppies like a cat? Absolutely. Absolutely. That self-tie with the hemostat. We We cord-tied cat ovarian pedicles with that tie too. We call it a different name, but it's the same technique. All right, preparation of the surgeon. Appropriate surgical attire, meaning you're not walking in from the barn in your coveralls and then immediately going into the surgery room. Caps and masks are required in those abdominal procedures and in castration of adult dogs, but not for cat and puppy castrations. All right. Hands and arms should be washed, followed by either scrubbing or the waterless surgical prep that a lot of people are using now. Either one is acceptable. Surgical gowns, the use of surgical gowns is left to discretion of the surgeon. Again, what we have to recognize, and I'm sure there will people out there, especially in the academic world, and a lot of us on this task force were from the academic world. I know we'll be able to find people in the academic world that say, oh my God, you're telling people they don't have to wear gowns when they spay an animal. Yeah, and the reason is because in the academic world, sometimes those spays take 3 hours, and in the high-volume spay-neuter surgery world, sometimes they take 3 minutes. There is a difference. All right. Single-use sterile surgical gloves are required for abdominal surgeries and adult dog castrations, and either single-use sterile surgery gloves or examination gloves are acceptable for cat and puppy castrations. The surgeries need to be done by a veterinarian or a supervised veterinary student. All right? You should use gentle and meticulous tissue handling, aseptic technique, small, properly located incisions that help reduce tissue trauma and reduce surgical time. The guidelines specifically state that interrupted or continuous suture patterns are acceptable. Where you make your incisions basically and what suture patterns are left to the surgeon's discretion, but we specifically wanted to state here are the things that are acceptable. Yes?
About supervised veterinary student, does that mean the supervising veterinarian is in the room or scrubbed in at the table with them?
All right. The question was, when it says supervised veterinary student doing the surgery, does it define the level of supervision? Does the veterinarian have to be scrubbed in, or is the veterinarian just present and observing? We do not get specific. It could be either. And I think it's up to the veterinary surgeon's discretion based upon their confidence of the skill level of the student. Yes, sir.
In New Jersey, when you were saying before, state law would always supersede. We actually helped get the law passed in New Jersey, allowing for student surgery. So if you're doing one in New Jersey, the law says that it has to be under the direct one-on-one supervision of a vet, not just specific. So there are situations, at least I know for sure, where we practice where you couldn't oversee a room of students. It has to be one-on-one. Yeah,
and it's just hard. There was no effort to try to review 50 different state practice acts and try to make the guidelines compatible. That's why we make that global statement. Be aware of what the requirements, the legal requirements are in your state, because they may supersede these guidelines. Good point. All right. For ovarial hysterectomy or ovariectomy, both are considered acceptable. The requirement is complete removal of both ovaries. The document specifically says that pedicle tie in cat space is perfectly acceptable. And it talks about either ventral midline or paramedian approaches. And if so, the closure has to include the external rectus fascia. It also talks about flank spays, where the enclosure must include the transversus abdominis, internal and external abdominal obliques. All right. And who was it that it was Michelle this morning that was talking about Sarah White's paper on fetal euthanasia, you know, what do you do for when you spay that pregnant cat or dog? What do you do with the fetuses? And fetal euthanasia is not necessary unless the uterus and the amniotic sac are open. So if you leave the uterus intact and the fetuses are still in the uterus, you just put them to the side, and you know they're not conscious, they're not sentient, they're not going to know, they're just going to die on their own. Yes?
We were just talking about it here. Isn't it acceptable in Europe where they're removing the ovaries and leaving the uterine body and the uterine?
That's why ovariectomies, yes, right here, ovariectomies are acceptable. All right? You know, that old concept of stump pyometra, if you leave any of the uterus, no, it's if you leave any of the ovary. As long as you get the ovaries, you're okay. Yes, in the back of the room.
Question: how expecting or what percentage of veterinarians in the U.S. are actually doing ovariectomies?
What percentage of veterinarians in the United States are doing ovariectomies? I don't have a clue. I would suspect that it is still extremely small, but is growing. All right, and I think it becomes simply the personal preference of the surgeon. My personal preference is I still routinely do ovarial hysterectomies because I can do them faster. All right? But that's the only reason I routinely do ovarial hysterectomies. It's because between an ovarian hysterectomy and an ovariectomy, the placement of the incision is identical. The length of the incision is identical. The one difference in the procedure is in an ovarial hysterectomy, I'm ligating 3 structures, and in an ovariectomy, I'm ligating 4. An ovariectomy takes me that much longer. How much is that? I don't know, maybe 30 seconds. I treasure my time. Those 30 seconds are important to me. I routinely do ovarian hysterectomies. But I do think the number of people that are routinely doing ovariectomies is increasing. And I'll go one step further. I think what this whole dialogue of ovarian hysterectomy versus ovariectomy has done is it has given people a comfort level of, I don't have to get all the way back down to that bifurcation if for whatever reason in the animal I can't easily get there. I don't have to extend my incision. I don't have to bend the animal 90 degrees on the table. I can then, in that situation, ligate the 2 horns independently and leave a bunch of the uterus in, because the important thing is getting the ovaries out. I hope I answered your question. Yes?
In the case of a client-owned animal, would you mention that you only remove the ovaries?
The question is, in the case of a client-owned animal, would I mention that we only remove the ovaries? Yes, if for whatever reason we're doing just an ovariectomy, I would absolutely let the owner know that. And now, if I happen to leave a ½ centimeter of both horns of the uterus, I'm not going to bring that up to the owner. All right? If I leave a little bit more uterine tissue than I normally do, I think that's irrelevant. But if I specifically go in to do an ovariectomy, and I have done that on occasion, I'm going to communicate to that to the owner that what we're doing today is an ovariectomy, and this is why. And oh, by the way, nothing to worry about because. All right. Yes?
So what were your whys that you were doing that, and what were some of the circumstances where you were doing just ovariectomies?
The question is, what are the reasons that I might do just an ovariectomy? There's basically one situation where I lean towards doing an ovariectomy, and that is those dogs that are in heat. Right? Because the uterus is so vascular, now what I find in dogs that are in heat is I'm probably ligating 5 structures in when I do an ovarian hysterectomy, because I'm ligating both ovarian vessels and ligating the ovarian body. So now an ovariectomy is faster for me because I'm ligating only 4 things rather than 5. So if an animal comes in heat, I'm going to communicate to that owner. Now recognize that most of our animals don't even have an owner, so this is a very rare occasion. But if I am doing an owned animal that's in heat, I communicate to the owner that we're going to do an ovariectomy rather than an ovarian hysterectomy, and this is why.
So in your model, with what you are doing in Mississippi when you're going out with your units, you're really not working on any privately owned low-cost animals, are you? Only doing mostly shelter animals?
About 95% of our animals are shelter. About 5% are owned animals by low-income families, because we call them community spay days. They're all organized by a couple different shelters where we go out, and the shelters have actually broadcast in their community that for people of this income level, we have an opportunity for you to get your animals spayed or neutered on this particular date. The people bring the animals to the shelter personnel do all of the intake stuff and all of that. We show up, and really it's invisible to us. We've gone to the same shelter. We're just doing owned animals that day. All right, and so, but that's certainly no more than 5% of what we do. All right. Yes, there was a question in the back somewhere. Yes, Laura.
I do all owned animals, and there's 2 other instances where I like to use ovariectomies. I don't do it very often, but one of them is if you have a bitch that's had a C-section, and then you have to spay her later when everything in the abdomen's stuck to her. Super easy to do an ovariectomy, super hard to try to peel everything off of the uterus on the way down. And then I also like to do, did everyone hear the first one? I said I like to do it 2 instances. The first one is if you have a bitch that had a C-section previously and everything in the abdomen stuck to her uterus, just do an ovariectomy. It takes you a lot less time. And number 2 is postpartum ferals in particular, just because a lot of times their uterus is like a piece of chewing gum, and when you try to pull the bifurcation out, the whole thing rips, and then you get Tourette's syndrome, and you're like, God, I hope someone props the belly because this is a mess. And I'm talking about flank space, and so I'll do ovariectomies on flank space, on ferals, and sometimes if I have an owned cat. Honestly, I don't bother telling the owners because most of the time they're so confused by it. Either way, their dog or cat is not going to go back into heat. I do have a special charge I put on that. It has a quick little statement that says, we elected to only remove your dog's ovaries today. Don't worry, she's still sterile.
So the brief answer was Laura's talking about 2 other situations where she elects to do ovariectomies. One is that animal that had a C-section at some point in time, and so in all likelihood there's tremendous adhesions to the uterine body, and so it's much easier and quicker just to take the ovaries in that situation. And then the other was the postpartum feral cat, where many times the uterus is, her terminology was like chewing gum or wet paper towels, and it tears so easily that again it's much safer just to take the ovaries. Yes, sir.
I watched your video on spaying a big dog, and it didn't say anything about individually ligating the uterine arteries.
No, it's not.
1 Miller's not.
Yeah, it's not necessarily big dog. It's dog in heat that has huge blood supply to the uterus. All right, it's not necessarily the size of the dog. It's the size of the vessels. All right, moving right along. For castration, for orchidectomy, the specific surgical procedure varies depending on the program and the surgeon's preference. The requirement is both testicles need to be removed. The guidelines document for a pre-scrotal approach, you want to close the subq and the skin. For a scrotal approach, and it specifically mentions scrotal approaches being acceptable, closure is optional. And in cryptorchid, you want to remove the undescended testicle first. All right. Pediatric, the guidelines document that the AVMA supports pediatric, has a policy supporting pediatric spay-neuter to help reduce overpopulation. The specific procedures used, techniques used are up to the surgeon's discretion, and it's acceptable to do them as young as 6 weeks of age. All right, under suture material, the critical thing is that you want biomedical grade suture that's approved for medical use. It needs to be sterile, and it should be dated for current use. All right. Antimicrobials are not considered necessary, and if they're used, ideally they should be administered prior to surgery or as soon as a break in asepsis is recognized. If skin glue is used, it should be used appropriately, which means applied to the surface of the skin, not in the wound itself. We all probably know surgeons that kind of intentionally spread the edges of the wound, insert the glue in as a foreign body in the wound, and then stick the skin back together, and now the body has to remove that foreign body. Skin glue, oppose the edges of the wound and put the skin glue on the surface. All right. It recommends tattoos, and it recommends, we recommend the green tattoo ink for the simple reason is we've never seen a green dog or cat. All right. And the guidelines specifically say that in females you want the tattoo to be on or near the site of the ventral midline incision. In male dogs you want it lateral to the prepuce, and in male cats you want it in the same location as female cats. All right. I don't think the guidelines specifically say, but oh, by the way, if you do flank spays, it does absolutely no good to put a green tattoo up here on the flank. You put it on the ventral midline where the ventral midline incision would occur. And for community cats, we recommend the ear tip. And I don't think the guidelines go this far. I honestly don't remember, but I liked Michelle's answer this morning of, oh, by the way, tattoo them as well. All right. Postoperative recovery. We look at the recovery procedure, any postoperative complications, analgesia, anesthetic reversal, return to patient housing, discharge of patients, postoperative care instructions. All right. You want a smooth transition from the anesthetized state to a wakeful state. All right. So that dictates a clean, comfortable environment where the patients can be kept warm and can be monitored. All right. You want someone to assess the patients immediately after surgery. You want to minimize the risk of complication and staff injury. You want continued observation on a secure level surface, that beach that they can't fall off of. It should be clean, it should be dry, it should be warm. You should try to minimize noise. You want to position the animals so there's no airway restriction. It's perfectly acceptable to recover litter mates together. Community cats, you want them to recover in their traps or their carriers, or you die. All right. It gives a whole list of things that you should look for, and again, because of time, I'm not going to read this to you. But it's all the logical things of hemorrhage and pain and hypothermia and hyperthermia and on and on and on and on and on. All right. You want postoperative analgesics. The requirements may vary from patient and with the amount of surgical trauma, but you have to have systems in place to provide postoperative analgesia to all patients. All right, and that may be include dispensing medications. It may be writing prescriptions, or it may simply be providing contact information. Let us hear from you if this or that or whatever. Postoperative pain medication, though, is not a substitute for atraumatic surgery. All right? All right? We recognize that there's an awful lot of things that you can do in surgery to minimize postoperative pain by minimizing tissue trauma. And again, I'll go back to that. The comparison between the 5-inch incision or the half-inch incision is one of them. All right. Anesthetic reversal is certainly acceptable. It can be performed. It specifically has benefits in the pediatric. All right. When you return the patients to the housing, make sure you get the right animal in the right cage. I mean, that's a no-brainer, but hey, it's in the guidelines. You want periodic evaluations of the animals once they've been put back in the cage. There's been studies out there that say the most frequent time for post-anesthetic and post-surgical complications is 2 to 3 hours. Isn't that correct? 2 to 3 hours after the surgery. So if you simply shove them in a cage once they're sternal and everything and never look at them again, you're putting those patients at risk. All right. Patients should be evaluated immediately prior to patient discharge. The skin edges, you want the skin edges to be clean and dry and well opposed. You want the patients to be sternal, alert, responsive, and you want dogs to be ambulatory. And you return trapped cats when they're mentally alert, oriented, and able to get around and take care of themselves. You want written and verbal postoperative instructions. All right. And operations management, I think it's going to be a stretch to go through operations management in 2 minutes. All right. But I'm going to try to hit the highlights. And in the last slide, I provide a couple links where you can access and download this full document if you don't already have it, if you haven't gotten an AVMA journal yet, or if you don't get the AVMA journal, I'm going to provide links, and I highly recommend you download the document. All right, the whole concept, I think, and I'll just have to do it this way, the whole concept of this operation management section is you want to have systems in place that allow for continual improvement in your anesthetic protocols and in your surgical techniques. All right. And the concept being, if you're not tracking how your patients are doing, you really don't know how they're doing, and you don't know when anything needs to change. So you want to very carefully track complications or problems during anesthesia and surgery or postoperative complications, so you can periodically look back and say, here's where we're having problems, and it could be, oh, by the way, here's the surgeon where all of our problems are coming from, or here are the techniques that we seem to be having greater complications from. Operations management, though, also deals with not just the health of the patients, it deals with the health and well-being of the staff. All right, so you need to have systems in place to determine, are we creating problems? Again, it was Michelle Antower's presentation this morning that talked about Sarah White's paper on ergonomics. You know, is the setup we have for our surgeons minimizing muscle strain and lower back pain, or is it exacerbating it? Looking at those things. Most of us are aware that the suicide rate of veterinarians is much higher than any of us would like. I guess 1 is much higher than any of us would like. But from the standpoint of looking across professions, suicide rate in veterinarians is way too high. There should have systems in place and information available for the veterinarians that work in these clinics and for the staff that work in these clinics for mental health counseling, stress counseling, and this type of thing. There should be leadership training for management personnel in these clinics. And again, I know I have absolutely shortchanged this section, and I apologize for that. But what I recommend, I am out of time, and what I recommend is that you download this document. You can read this section as easily as I can talk about it. Here are the links. You can, the easiest one is to go to sheltervet.org. That's the ASV's website. And if you scroll down on the right-hand side of the screen, there's a little blurb about the updated guidelines, and there is a link. You click on that link. It says direct link to updated guidelines, and it brings up a PDF version of the document for you. The other reference here is the specific reference to the document at the AVMA's website. This Shelter Vet direct link goes to that specific website as well. I am out of time. Thank you very much.